It is 8:30. We are going to get started right on time because we have a lot of exciting content to cover. So for today, we are going to have the first of two CROI report backs to cover all the things that we may have missed or saw, but wanted to go into more depth. We're really lucky to have both Drs. Kate Koss and Dr. Matt Spinelli, both faculty members here in the division. And without further ado, I'm going to turn it over to Dr. Koss.
Great. Well, thanks, Matt, and thanks everyone for joining us today. We are really delighted to present report backs from CROI. These are our disclosures. I'm going to be covering long-acting ART strategies and a bit about PEP, and then Matt is going to cover CAB-LA implementation, STI prevention, early phase studies of ART and prevention. And I'll just start by saying that CROI was a fantastic conference. It was in Denver, and really wanted to give a shout out to the community educators and advocates who play a really important role at CROI, the program committee and chairs, including our own Dr. Diane Havler, and the IAS committee, IAS USA committee with Donna Jacobson and others who work so hard all year to put on CROI. So with that being said, let's start with our current long-acting ART regimen of cabotegravir lenacapavir. As this group knows, phase 3 registrational trials showed non-inferiority of a switch to Cabril in patients with viral suppression. And some of the considerations that we think about when we switch individuals are, of course, having no major CAB or rilpivirine mutations, being able to receive injections on a schedule, since these are every 4 or every 8 week injections, and Hep B status, always important to remember, since these agents, of course, don't cover Hep B, and accompanying oral regimens would be needed. And at CROI 2024, we saw new data on switch to CAB-rilpivirine in diverse patient populations and in patients with adherence challenges. So I'll start with the CARES trial, which is a randomized trial of CAB-rilpivirine every 8 weeks compared to standard of care oral ART using a public health approach in Uganda, Kenya, and South Africa. And this trial was motivated by differences in population between ART programs in Southern and Eastern Africa and the populations in registrational trials. In ART programs, typically over half of individuals are cisgender women. There are different HIV-1 subtypes and typically high levels of prior NNRTI use due to many years of efavirenz being first-line treatment, and high levels of pretreatment NNRTI resistance, which could impact the use of rilpivirine in these settings. So this was a phase 3b randomized open-label trial of a public health approach with no baseline genotyping, given limited availability in many ART programs, and viral load monitoring every 6 months, which is consistent with the standard of care. So this trial enrolled adults who were on stable oral ART with generally dolutegravir or efavirenz. They had to be virally suppressed for within the year prior to and at screening, and had no history of treatment failure. About half of individuals who were screened were excluded due to Hep B. And after enrollment, individuals were randomized to either continue oral ART with standard of care or start CAB-rilpivirine with an optional oral lead-in followed by every 8-week dosing. As I said, viral loads were done every 24 weeks, so less frequently than we tend to do here. And in terms of enrollment, there were 512 individuals who enrolled, 57% women. 3/4 had a prior history of NNRTI use, but no history of failure. And over 90% were currently on dolutegravir-based ART at the time of switch. They did not do any baseline genotype testing, but at baseline for the trial, blood was collected, PBMCs were stored, and there was retrospective testing at the end of the trial for archived proviral DNA to look for resistance. And interestingly, there were about 16% of individuals who had cabotegravir resistance, any cabotegravir resistance, and 12.5% who had any rilpivirine resistance. So these are individuals who, if we had sort of standard genotyping, would have potentially been excluded from getting Cabril in our setting. In terms of the results, Cabril-pivirine was non-inferior to oral ART at week 48. There were very high levels of viral suppression, 97% in each arm. There was very high adherence to the injection schedule. And importantly, there was higher treatment satisfaction in the Cabril-pivirine arm. There were no confirmed virologic failures in the standard of care arm. In the Cabril-pivirine arm, there was one individual with confirmed virologic failure. no known baseline resistance, but at failure had high-level rilpivirine resistance, low-level dolutegravir resistance, and actually resuppressed on sort of the standard first-line single-tab regimen TDF 3TC dolutegravir once daily, which was good news. There was another individual with unconfirmed virologic failure who had at baseline low-level rilpivirine mutations, and at failure also had new high-level cabotegravir resistance. So in terms of implications for our setting, I think there are a few points to note. There was a very high viral suppression, again, interestingly, despite 12 to 15% of participants with baseline CAB or rilpivirine resistance on an archived PBMC genotype. I think there are some differences from many of our patients. These were patients who had no history of prior ART failure. Most had perhaps 2 prior regimens, for example, efavirenz to dolutegravir switch, no treatment failure. So I would have some caution with applying this to our patients, some of whom have a history of extensive treatment, multiple regimens, and I think it will be helpful to see the durability of the results out to week 96. There was a lot of interest in this finding around the resistance. And then secondly, as we have more rollout of cabotegravir, rilpivirine in different populations, as you may recall in trials, one of the risk factors for virologic failure was subtype A1 or A6. There were very few participants in trials with subtype A1. Half of participants in this trial had A1 and did very well. It seems like more of that failure may be driven by A6 as opposed to A1. And then third, as we think about sort of intensity of monitoring, this was a study with every 8-week injections. We are doing that a lot now, but also Q24-week viral load monitoring. And I think this raises the question of whether there could be less frequent sort of in-clinic visits and lab monitoring, and whether this could facilitate additional low barrier care for injections in the community at non-clinical sites and with less frequent phlebotomy. And I think that merits further study. So the second study we'll discuss is the MOCA trial, which is the first trial in adolescents with rilpivirine as their sole ART regimen. Adolescents are a really important population who tend to have lower viral suppression and are often excluded from registrational trials. Based on data from an earlier cohort 1 of this trial, rilpivirine is FDA approved for virologically suppressed adolescents, at least 12 years and weighing at least 35 kilograms. But that was based on safety data where individuals continued on their oral ART and then received either CAB or rilpivirine injections on top of that. So it wasn't really assessed as a standalone regimen. So in this study, which is cohort, and those results were just published in Lancet HIV of note. In cohort 2, which was presented at CROI, individuals switched when virally suppressed from their background ART regimen to CAB rilpivirine. This study enrolled at 18 sites, including in the US, but also in sub-Saharan Africa and in Thailand. And individuals received an oral CAB ril lead-in, followed by switch to every 8-week dosing. They presented the week 24 results, and individuals will be followed out to week 96. So the median age of participants was 15 years, half were female, 74% Black or African American, and 92% had perinatal HIV acquisition, which I think raises the question of how many prior treatment regimens, potentially a very treatment experienced population. We didn't get those data in the presentation, but most were on NNRTI or INSTI-based ART at the time of switch. The investigators excluded participants with known or suspected rilpivirine or INSTI mutations, but they did not collect genotype data or perform genotype testing in the study. In terms of outcomes at week 24, 96.5% maintained viral suppression. There were no confirmed virologic failures. 35% had injection site reactions, but none required stopping CAB-RIL. And in a PK analysis, CAB and rilpivirine troughs were similar to adults also receiving every 8-week dosing. And importantly, 99% of participants preferred long-acting injections over oral medications. So for take-home points here, I think these data support the FDA label for use in adolescents. CAB rilpivirine every 8 weeks was safe, well tolerated. There was high viral suppression through week 24. And I think, again, really importantly, high satisfaction with this first long-acting injectable treatment in an important population with potential challenges with adherence, stigma, and disclosure. There was an accompanying behavioral science abstract that was a poster. And this is just one quote from that poster from a 12-year-old girl who participated in the study. And she said, and so it gave me the opportunity to live like a regular human. If someone were over at your house or something, they wouldn't have to see you taking medicine and wonder why. So I think the patient perspective here is really important. So let's now talk about a long-acting ART program in a diverse urban clinic at the University of Chicago. This is a clinic that serves a population that's 85% Black, 1/3 female, does have individuals with mental health and permanent housing challenges. They have a robust pharmacist and nurse-led program for CAB rilpivirine. And they analyzed data in terms of what was the uptake of Cabril in individuals, whether they were virally suppressed at referral or not suppressed. So in individuals who were virally suppressed at referral, 71% actually started Cabril, 86% remained on Cabril and virally suppressed at 8 months. In contrast, there were 12 individuals who were not virally suppressed at the time of referral. And of note, the clinic did require achieving viral suppression prior to Cabril start, but they looked at sort of the data on these 11 individuals who didn't start, median viral load 15,000, and many had a history of non-adherence to oral ART, low engagement in care, unemployment, and or unstable housing. So a lot of barriers to overcome, to really be asking patients to overcome prior to starting Cabril. So the investigators noted that while there was significant uptake and viral suppression on Cabril in this diverse population, really more work is needed to support patients, providers, and clinic systems to deliver Cabril-Pivirine to patients without viral suppression. And this really, I think, as we know at Ward 86, takes a team and a lot of coordination. So this team at University of Chicago is planning some exciting innovations with a multidisciplinary care team and new low barrier care models with intensive case management to help support this particular population. So speaking of patients with adherence challenges and use of Cabril in this population, really, as this group knows, the trials in most clinics are using Cabril in patients who have already achieved treatment success on oral ART. But one might think that to maximize individual and population level benefits of this strategy, sustained health, reduced progression to AIDS, and reduced transmission, we really need strategies that are inclusive of patients with barriers to adherence to oral ART and or viremia. So at Ward 86, this has been a population that's been included in the long-acting ART program led by Dr. Gandhi and others. And in this, in the program at Ward 86, individuals don't need to be virally suppressed or take oral ART before starting injectables, but do need to express willingness to come to clinic because these are fairly frequent injections and receive outreach from staff. And there's a rigorous protocol ensuring patient safety. So Matt Hickey and others presented a beautiful poster on 48-week viral suppression in the subset of patients at Ward 86 who have started Cabril-Pivirine without viral suppression at start. There were overall, there have been 286 individuals who started long-acting ART, including those with viral suppression. And early data suggests that viral suppression can be achieved in most patients who start in the setting of viremia, but there was really no data on whether this initial viral suppression is sustained over time. So this was a retrospective analysis of 48-week viral suppression among 59 patients who started Cabril with a baseline viral load at least 50. 69% had a viral load of at least 10,000 at baseline, and half had a CD4 count less than 200. So important population at high risk of progression with AIDS-defining illnesses. Half had unstable housing, and over half had a history of substance use. So in terms of results, overall, 48 out of 59 individuals who remained on Cabril-Pivirine had a viral load of less than 50 at week 48. That's 81%. When we include individuals who were on alternative ART or Cabril-Pivirine, this number goes up to 93%. And when we look at a viral load of less than 200, 95% of this group of 59 had a viral load of less than 200 at week 48. And I think these are really impressive results. And as a reminder, there was 0% viral suppression in this group at the time of starting Cabril-Pivirine. So I think these results continue to show that long-acting ART is an important tool for improving viral suppression among patients facing adherence challenges. There were also results at CROI from a phase 3 randomized trial of a long-acting ART strategy in populations with adherence challenges. Also very exciting results. This is the Latitude trial that was presented as a late breaker. And this study enrolled individuals, including here at San Francisco General with Annie Lutkemeyer and others, who had patients who had a poor viral response to ART or who had a history of non-adherence. Hep B was exclusionary and resistance mutations. And then there were a couple steps in this study. So the first was actually to stay on oral ART and then receive intensive adherence support and conditional economic incentives with the goal of achieving viral suppression on oral ART. So individuals who achieved a viral load of less than 200 could then be eligible for randomization to receive long-acting Cabril-Pivirine every 4 weeks or standard of care oral ART. The study population was 30% female, 64% Black. At baseline, 68% had a viral load of greater than 200, so baseline for step 1. And then at step 2, remember, you had to achieve viral suppression to be randomized, but at the randomization visit, some individuals became viremic again on oral ART, so 17% in the Cabril arm, 7% in the standard of care arm actually had a viral load above 200 at the start of step 2. In terms of results, 93% of injections were on time, pretty impressive for this population. 57% had injection site reactions. I'm going to walk through the different outcomes here. So first, looking at virologic failure. So the week 48 cumulative probability of virologic failure was 7% in the Cabril arm, so this is in red, compared to 25% in the standard of care arm. There were 6 participants in the Cabril arm with confirmed virologic failure. And this difference was 18% between the 2 arms, favoring Cabril-Pivarine and demonstrating statistical superiority. So better for virologic failure. Next, for treatment-related failure, this was a combined outcome of the first occurrence of virologic failure. So our 6 participants in the Cabril arm who had virologic failure plus treatment discontinuation due to an adverse event. That's 3 individuals. So collectively, about 10% of individuals in the Cabril arm compared to 26% in standard of care experienced this outcome. The difference was 16%, again, favoring the Cabril-Pivarine arm and demonstrating statistical superiority. So the DSMB stopped the study early in February 2024 due to the superior efficacy of Cabril-Pivarine in these secondary endpoints. And I'm going to walk through 2 other endpoints that also informed our primary outcome here. So an additional endpoint was permanent treatment discontinuation, but this was discontinuation not necessarily due to an adverse event or virologic failure. But you can see the number of individuals who stopped Cabril-Pivarine and standard of care here. Number goes up for Cabril, 21% compared to 25% in standard of care. There was a difference of 4% and not statistically significant. And then the primary outcome combined virologic failure and permanent treatment discontinuation. So 2 of these. So let me show you the primary outcome here, which is now on the left. This was the first event of either treatment discontinuation or virologic failure. So 24% of individuals in the Cabril arm compared to 38.5% in the standard of care arm had what was termed regimen failure. And again, in the Cabril arm, this was largely driven by the treatment discontinuations, not necessarily due to adverse events. This was a difference of 15%, but did not quite reach statistical significance with a 98.75% confidence interval. But again, I think take homes here, virologic failure, treatment-related failure, superior in the Cabril arm. What about confirmed virologic failure? There were numerically far fewer participants in the Cabril arm, 6 compared to 28 in standard of care who had confirmed virologic failure. As we know from trials, it's possible when the regimen fails a patient to develop high-level Instiant and NRTI resistance. Of the 2, there were 2 individuals of 6 in the Cabril arm who had confirmed virologic failure with resistance. Both had high-level cabotegravir resistance. 1 had high-level rilpivirine resistance at the time of failure. There were 3 additional participants who had failure with no new resistance, and 1 with a viral load of less than 400, no genotype. These 2 participants who had failure with new resistance did subsequently achieve viral suppression on an oral regimen. So I think in terms of take-home points on Cabril among patients with adherence challenges or starting with viremia, so we have accumulating data on the effectiveness of Cabril among patients with adherence challenges or viremia in routine care from multiple or several clinic settings. The Latitude trial showed that Cabril-Pivarine every 4 weeks was superior to oral ART in a diverse US population with a history of adherence challenges. And excitingly, the IAS USA guidelines were updated on March 1st as a result of these accumulating data. We're still awaiting whether and to what extent DHHS guidelines and the FDA label may be updated. But for IAS USA, this was published in JAMA the beginning of the month. And what they have said is when supported with intensive follow-up case management services, Injectable Cabril may be considered for people with viremia when no other treatment options are effective due to persistent inability to take oral ART, and in individuals who have a high risk of disease progression, CD4 less than 200. And again, thinking about our Ward 86 cohort, that really many of the individuals, about half, had a CD4 less than 200 at the time of start when viremic. So this is an exciting, I think, change with the IAS USA guidelines, and great to see practice-changing data coming from Ward 86. So what about patients who cannot take oral ART and have rilpivirine resistance? I think this is a really important population as we're thinking about long-acting and whether we could use cab-len off-label in these individuals. As a reminder, lenacapavir is FDA approved with optimized background regimen for patients with multi-drug resistant HIV as a sub-Q injection given every 6 months. It's also being studied for other indications as well, as Matt will talk about. And this was a case series of the off-label use of len and cab, really thinking about this question of rilpivirine resistance. So both in the US and globally, where we've talked about sort of high levels of NNRTI resistance, there really is a need for strategies that are long-acting but do not include rilpivirine. So this was a case series of 4 clinics that have, at least in some patients, used off-label len and cabotegravir in patients who have adherence challenges to oral ART. 59% had documented or suspected NNRTI mutations. And of the 34 patients in this case series, early viral suppression, so at a median of 8 weeks after starting len, doubled from 47% to 94%. So very exciting, sort of very early results, but showing potential proof of principle that this regimen could be effective in individuals, and small trials of long-acting cab and len are planned, which we're excited about. So in terms of implications of our long-acting ART data from CROI, I think really thinking about, we're still early on in this long-acting ART era, really thinking about individuals with barriers to ART who could benefit most from these regimens. How do we make this more accessible? And this is, I think the team at Ward 86 has done an amazing job setting up a system to facilitate starts in both for patients and clinical teams. This is not easy to do. It's hard in many settings to sort of, particularly for prevention, to get access to drugs. So how do we now set up clinic systems that support both patients and clinical teams to provide current regimens for treatment and prevention, and also lay the groundwork for forthcoming regimens, long-acting, oral, and injectable? So finally, I'll just say a few words about post-exposure prophylaxis, sort of transitioning over to prevention here. There was a theme discussion on PEP at CROI, which was great. And really, after decades of availability, PEP really remains underutilized as part of our kind of primary prevention toolbox. There was a presentation by Mary Tanner at CROI that showed in this figure here HIV PEP and PrEP prescription trends over the last decade, since there were PrEP guidelines released in 2014 and updated PEP guidelines in 2016. And you can see that PrEP prescriptions, which are in blue, have gone up nicely. I think we're not where we need to be with PrEP, especially in terms of equity, but certainly those prescriptions have gone up. But PEP prescriptions have remained completely flat. So I think there's sort of a missed opportunity here where PEP, either with PEP to PrEP transition or PEP in pocket, which sort of allows for infrequent exposures, having PEP on hand if you need it. Those options could really increase biomedical prevention coverage. In this theme discussion, the point was made that the guidelines don't currently recommend an INSTI-based single tablet regimen that could really make prescribing easier for non-HIV experts who are often tasked with trying to start PEP and knowing what to do, and could also improve adherence and completion from a patient perspective. Daryl Tan and colleagues from Toronto presented data on using BIC-F-TAF for PEP, showing high rates of completion. It was well tolerated, similar to findings from 2 other prior published studies. And of note, this regimen has been used at City Clinic for many years, usually with PEP to PrEP. The CDC is finalizing updated PEP guidelines, which we're very excited about. So please stay tuned for those. And I will now turn it over to Matt. Thank you.
Sorry. All right, great. I'm going to jump right into this. Thanks so much for having me, to the organizers of Grand Rounds. Okay. So the first study I'm going to discuss is the randomized trial of search dynamic choice HIV prevention, including injectable cabotegravir This was an abstract presented by Dr. Moses Kamya and also the study team and PI, including Dr. Havler, Dr. Koss, and Dr. Shami, who are all here today. So the intervention of dynamic choice HIV prevention, it included person-centered care, notably phone access to a clinician 24/7, as well as a comprehensive sexual health, reproductive health services. Patients could switch between oral PrEP, PEP, which was supplied by the Ministry of Health, and CAB-LA, which was supplied by the study, but at Ministry of Health clinics. The control was the country standard of care, which included oral PrEP and PEP, but it did not include cabotegravir long-acting. So, I think very exciting to see such a dramatic difference in coverage in these two groups. 56% of participants used CAB-LA during the study, 53% used oral PrEP, 2% used PEP, and 2+ products and 28%. And the standard of care, only 19% used oral PrEP, 1% used PEP. I didn't show the heat map here, but I would say the majority of person time was with CAB-LA in the dynamic choice arm. Or the plurality at least. So there were showing here the primary outcome, which was coverage based on self-reported adherence to oral PrEP and PEP and injection logs to cabotegravir. You can see a really dramatic difference in coverage of 56.4%. And this, I think, without a statistical test, clear that this was true across all subgroups. And I should say these are communities in Kenya and Uganda. I realized I didn't say that. Also very exciting is the HIV incidence data. 0 HIV infections in the intervention arm, which is just absolutely remarkable. 7 participants in the standard of care arm experienced seroconversions, and unfortunately there was 1 vertical transmission in the standard of care arm. This was a risk difference of 1.8%, which was statistically significant. This is from the grand rounds that Sarah Purrier, Dr. Purrier, and I gave last year, last spring. And just to remind you that we're also not where we need to be here locally. And if we could expand the coverage of PrEP, expand the pie, not just switch people from oral PrEP, but increase the amount of people who are using PrEP, that's where we're going to see the most dramatic difference in HIV incidence. A 10% increase in PrEP coverage would decrease our HIV incidence in the Bay Area by 48 to 49%. And so that's why this search data is particularly dramatic and important pathway forward for how we need to also act locally. We need to offer patients product options and allow them to change over time using patient-centered approaches. We need both wider access to CAB-LA and patient-centered models, and we need to really speed up the global rollout, including here in the Bay Area of new PrEP options. So this abstract is a little bit confusing, but I'm going to try to walk you through it. This is site-based HIV testing assay performance for cabotegravir and TDF-FTC PrEP failure in HPTN 083. To remind you, HPTN 083 was one of the 2 cabotegravir registrational trials. This trial included men of sex with men and transgender women, and they were randomized 1-to-1 to either CAB-LA plus TDF-FTC placebo or CAB placebo and TDF-FTC every day. One really important point about the study design is that it did not initially include viral load testing. They were trying to be, well, I guess they didn't predict that this was going to happen, and also they were trying to be as real world as possible. Unfortunately, in this study, back testing revealed that infections could have been detected earlier with viral load testing, and that sort of serves the background for this study. The reason why this occurs, why viral loads may be needed in cabotegravir follow-up, is this long-acting early viral inhibition syndrome, or Levi syndrome. I'm not going to go through this in total detail, but suffice it to say that seroconversions that we see on cabotegravir long-acting due to the really long the really long half-life of this drug and potentially the agent are quite subtle with minimal symptoms. They're smoldering. They can exhibit prolonged negative antigen antibody and rapid test negativity. And a viral load, at least in what's been presented so far, appears to detect these infections much earlier and generally before the development of integrase resistance. So that has led to the CDC guidelines saying to do viral loads with all cabotegravir follow-up. They also say all oral PrEP follow-up, which is another thing that we'll talk about a little bit later. This study did not assess what negative tests meant. They only assessed what positive tests meant. So that's why this is a little bit confusing. But what they did show is that when a rapid test and an antigen antibody test are positive, there are 0 false positives. So in clinical settings, when you're seeing these patients, if you have 2 assays, I would say rapid test plus antigen antibody test to be as close to the data as possible, you need to initiate rapid ART as soon as possible. But if a test is negative, I still don't think we have the data to know that a viral load is not needed. Basically, I emailed Dr. Landovitz to talk about it, and the issue is because of the lack of systematic viral load testing. He's still worried there could be cases detected, and because viral loads are not done systematically, he really wants to wait for the 083 and 084 open label phases, which are including systematic viral load testing. Verbally, he said the negative predictive value is high, but I don't think that's totally including the timing issue that is so important in that, yes, maybe eventually they will turn positive, but potentially after integrase resistance is already developed. So for now, I would keep doing viral load testing if it's available at your site. Okay, this study is cabotegravir maintains protective efficacy in the setting of STIs, presented by Dr. Meredith Clement. The background of this is in the absence of PrEP, STIs increased HIV transmission efficiency, but it was unknown if STIs would impact PrEP efficacy. Studies have shown, I would say pretty definitively, that TDF-FTC and 2-degree TAF-FTC are not impacted by STIs, but it was not known for cabotegravir. One piece of the results that I thought was interesting to highlight was the dramatic concentration of STIs in a subset of the population of this study. A quarter of participants had 80% of the STIs. So these were their primary analysis. On the right is showing how they did this analysis. So if an STI was positive at the beginning of an interval of a study follow-up interval of 8 weeks, and then an HIV test was positive, that was counted as HIV positive in the setting of STIs. They looked at it the other way with the STI after the HIV diagnosis, and everything looked very similar. So what you can see is that CAB in the left column and CAB in the right column, STI absent and STI present, very similar, no statistical difference. In the TDF, you do see a bit of a higher HIV incidence in the presence of STIs. But of course, as we know, TDF-FTC, not everyone takes that with perfect adherence, and folks who are using PrEP and have STIs are probably at higher HIV risk. So I wouldn't interpret that in isolation. In any case, cabotegravir, similar comparative efficacy with or without an STI. So that's great news. STIs highly concentrated in a proportion of those seeking HIV prevention, and to remember that STI history is a really important clue to HIV risk. Please offer PrEP to anyone with a past STI, and we need innovations in STI prevention. Okay, so this was a test presented by Dr. Zhu from the CDC about few discordant antigen antibody and RNA test results among persons in a national cohort of PrEP users. This is sort of our follow-up to the discussion of Levi syndrome. This used a commercial insurance database, so it's not including our patients who would not show up in a private insurance database. It's not an enormous database comparatively to the number of PrEP users, so I add that as a caveat. There were about 8,000 tests in almost 5,000 oral PrEP users and 931 tests in 439 CAB-LA users. The CAB-LA rollout is slow, but we do have a good amount more than that, I would say, in the country. For oral PrEP, there was one case of an RNA positive with an antigen antibody negative. That was a likely HIV diagnosis. So that gives you 1 in 8,053 or 0.01% HIV antigen antibody false negative. In the CAB-LA group, there was one likely false positive RNA test and one test that was inconclusive. So no definitive cases of Levi syndrome seen in this real world cohort. I would say this was a big discussion of in the audience of why do the CDC guidelines say that you need to do an HIV viral load for oral PrEP? And it was implied that they would hopefully be changing very soon, because I think that's completely unnecessary and was based on a misinterpretation of the oral prep 083 data, in which administrative delays were thought to be true delays. So hopefully that'll be going away. But I do still believe that we need to be doing viral loads in CAB when they're available. So jumping into why is cabotegravir rollout so slow? This was a really provocative session. What this graph is showing you here, so the graph on the left, you can see the blue lines are branded FTDF, and then you can see as generics and FTAF come into the picture, the branded FTDF decreases as you'd expect. So we are continuing to see increases, although maybe not quite at the same rate we were seeing. This yellow line that is barely visible, almost blending into the x-axis, is actually cabotegravir starts. So currently taking up a very small proportion of PrEP that's being used in the US. And you can see the numbers here based on the CDC estimates, less than 3,000 people using PrEP, injectable PrEP. With some drop off from the first dose to the second dose to 84%. And Dr. Rupa Patel from the CDC went to discuss that a lot of discontinuation may be related to the challenges of delivering this medication in the US insurance landscape. So this is a little bit of a confusing graph. I'm not going to go into it in total detail, but it's really helpful as a reference when you look back at this. It's showing basically how many programs there are out there with injectable CAB programs. The red stars are representing programs that have more than 250 PrEP users. Unfortunately, there's not very many of them. Notable ones are Howard Brown in Chicago, Legacy Health in Texas, a program in Philadelphia, FIGHT, and Whitman Walker. She also mentioned that many programs have started and then closed, or several important anecdotes of programs starting and closing because of the complexities of obtaining the drug. Apparently with private insurance, which is frankly something that we don't deal with here, you have to do prior auths in some contexts every single time you obtain the medication. So that's very burdensome and requires a lot of staff time. Buy and bill is one potential really attractive solution where clinical programs could buy the drug and then be able to start people on cabotegravir much quicker without having to do all of the process to obtain the drug at the time a patient presents. Unfortunately, that really requires quite a bit of capital to be able to afford such an expensive drug to keep it on hand. So it really limits sort of this idea of rapid PrEP with cabotegravir in the US context, unless you use Medicaid insurance, which we have here, thankfully. So this is one example of public versus private insurance actually potentially improving equity. That's not a great in the a larger landscape, but we do see fewer issues with our Medicaid patients than with private insurance. Okay, so these were her summaries. Multifactorial issues contributed to delayed equitable CAB rollout. One thing I didn't mention is that product availability to studies has been extremely limited. So a lot of this work to figure out implementation has been limited by there's just not a lot of study product available. The pre-implementation phase is critical for sustained service delivery, and you need to have varied health staff to make these programs work. I would say in our program, I would highlight our pharmacists and pharmacy techs who make this happen. Policies are urgently, and as well as our nurse, Christy Camp, very important part of our team. Policies are urgently needed to accelerate the implementation of current and future products. So some, I think, honorable mentions that I didn't have time to cover. Dr. Koss covered the first case of CAB breakthrough with integrase resistance, and this falls into a similar theme of the challenges of insurance contributing to delays. The HIV RNA was 20 days before the injection because of delays getting started because of the insurance. This case likely was an acute HIV infection that was not detected within that 20-day window, leading to integrase resistance. CAB PrEP implementation, Dr. Hazra, that I already highlighted from Howard Brown in Chicago, showed that private insurance is leading to CAB start delays. Mills from the Opera cohort, large real world cohort, at least what we have with CAB, 498 people, 22% delayed injections, 11% missed, and 1 seroconversion due to testing not being performed on a CAB start. And our medical student, Bissam Rapp, working under Dr. Puryear, showing the Ward 86 PrEP cohort, which was notable for a population with a lot of structural barriers to starting PrEP, 50% not on PrEP before. And we also allowed rapid start, which was notable and got a lot of attention at the poster session. Okay, that was a lot. All right. Jumping in now to DoxyPEP and STIs, I would say this was a huge focus of the conference this year and a really very exciting moment in biomedical STI prevention. I'm going to focus most on the DoxyVax study because that had the most attention, and Dr. Lukemeyer has covered DoxyPEP in some detail here already. These are the final results of the ANRS 174 DoxyVax study presented by Jean-Michel Molina. And this was the design. So this was a factorial design, and it's even more complicated because the randomization to DoxyPEP was 2-to-1. So keep that in mind, that there's twice as many people on DoxyPEP than no PEP. That will influence your interpretation of the gonorrhea results, and was not highlighted at the presentation, which I think led to a lot of confusion in the media about gonorrhea resistance. So, and then those people in each arm were 1-to-1 randomized to the 4C Men B vaccine or Bexsero. This was based on some observational data that the 4C Men B vaccine had some cross protection to Neisseria gonorrhea, and was added to the study in that to test that hypothesis. There were 2 primary efficacy endpoints: DoxyPEP on time to first episode of syphilis or chlamydia, and impact of 4C Men B vaccine on time to first episode of Neisseria gonorrhea. In the full analysis, so the good news, the effect on first chlamydia or syphilis was similar to that seen in the preliminary data presented after the DSMB halted the study. Excuse me. There was an 83% reduction in cumulative probability of those 2 STIs to first diagnosis, and then a statistically significant but smaller impact on gonorrhea. This showed a 33% reduction in time to first gonorrhea in the DoxyPEP arm, which is good news because of a higher rate of pre-existing gonorrhea resistance in France. Unfortunately, and this is, I would say, quite unprecedented, the 4C Men B vaccine no longer appears effective after a data audit where apparently a file was not included in the presentation to the DSMB. And when those additional endpoints were located, it became no longer statistically significant. There's certainly a trend, 22% reduction, p-value of 0.061, but no longer statistically significant. What Dr. Molina said is, with this data showing, at best a very subtle impact in potentially a larger study, and a Neisseria gonorrhea vaccine in the pipeline from the same company that appears to have stronger in vitro data, this is not going to proceed forward for gonorrhea, and the next step will be to test the Neisseria gonorrhea vaccine. So a lot of talk was about gonorrhea resistance. Dr. Lukemeyer couldn't be here today, provided me this slide, which I thought was a great summary of resistance in both studies. One thing to remember, I'm going to go first the DoxyVac on the right, is that the 2-to-1 randomization, I think, was missed in a lot of the press. So it looks like there is a lot more resistant gonorrhea in the dark blue and the DoxyPEP arm. The light blue is intermediate resistance and the yellow is sensitive. But remember the 2-to-1 randomization. Certainly the proportion of highly resistant gonorrhea is higher in the DoxyPEP arm. And this interpretation that Dr. Lukemeyer gives here, I think, is perfect, that DoxyPEP is less protective against gonorrhea strains with existing resistance, but it does not prove that it does not say anything about whether DoxyPEP is increasing the rate of gonorrhea, as I saw in some news articles. So, and then I think you can see here, when comparing DoxyPEP and DoxyVac, the impact of less pre-existing resistance in San Francisco and Seattle versus France, that you see a much smaller proportion of highly resistant and intermediate resistant gonorrhea strains getting through because our patients were exposed to fewer of them. So my clinical takeaways would be DoxyPEP highly effective against chlamydia and syphilis. It is effective against gonorrhea, but is a bit less effective in settings with pre-existing gonorrhea resistance. The 4C Men-B vaccines impact on gonorrhea did not reach statistical significance, which is really, really sad. Me and a lot of my patients very excited about that. And there is a vaccine against gonorrhea that has high efficacy, that looks good in vitro, so the company is going to move forward with that. Okay, I'm going to cover this in a little bit less detail. Dr. Luca Meyer's study, sustained reduction of bacterial STIs during the doxy-PEP study, open label extension. This is, I thought, a really good summary slide that basically this is showing some of the open label data from the switch of people who were randomized to the control arm who then were allowed to transition to doxy-PEP. On the left, you're seeing the as randomized quarters, and on the right, the open label extension quarters. And you can see that the standard of care arm, when offered doxy-PEP, begins to look much more like the intervention arm in the original study, and the original intervention arm still maintaining the lower than expected STI incidence without the presence of doxy-PEP. You can see most of the breakthrough cases are gonorrhea, as we just discussed. So what got the most attention in the press was the sexual data. When folks went from the as randomized arm to the open label arm, so standard of care to doxy-PEP, the number of sexual partners doubled. Interestingly, in the original DPEP group, this was an open or original doxy-PEP group. This was an open label study. Similar number of partners over time. So the way I would interpret this is doxy-PEP shows sustained impacts on STI incidence in the open label setting, despite an increase in condomless sex acts. We should be meeting people where they're at and providing new options to prevent STIs instead of decrying increases in sexual acts. Offer doxy-PEP to MSM or transgender women with a recent STI or without HIV. And I think in sort of a patient-centered discussion, I would offer to other populations as well, particularly those who have past syphilis. We need to monitor antimicrobial resistance and effectiveness in the real world to understand population level impact. Unfortunately, with the difficulty of culturing gonorrhea, it makes it really hard for these studies to tell us much about AMR, antimicrobial resistance. We're really going to have to do a lot of population-based surveillance or develop better tests for resistance, such as genetic tests. Okay. So now we're going to be moving to some really exciting real-world studies. This is an ecological analysis of doxy-PEP being associated with declines in chlamydia and syphilis in men who have sex with men, and transgender women in San Francisco. A policy was released in November 2022 with collaboration of multiple important forces for STI prevention in the city, including City Clinic, the SF Magnet Clinic, SFTPH, UCSF, and Getting to Zero, a really concerted effort to get this policy out there earlier than a lot of other places, and to put things in place to handle a much a big increase in uptake of doxy-PEP. And the exciting news is on a city level. So this is city data based on mandatory reporting of STI diagnoses. An analysis looking at the slopes of syphilis and chlamydia over time. You can see prior to the release of the policy in November 2022, a slow uptake in syphilis and chlamydia in line with national trends. And then a really dramatic decrease in that slope after the implementation of the policy, with a 51% decrease in syphilis cases. I'm not going to show the chlamydia data because it looks extremely similar to the syphilis data, which is amazing to see. There was no impact on gonorrhea at the city level. I would say just remember, and it's surprising to see the gonorrhea decreasing at the city level, which doesn't really fit with a lot of our sites we're seeing. I would say this is an ecological analysis, and we know that the impact of gonorrhea is less for doxy-PEP. So I think we need to wait and see if there will be a population level decrease with just doxy-PEP. This is an analysis that Dr. Hyman Scott presented at SF Magnet, SF AIDS Foundation, STD Clinic, Sexual Health Clinic. What you can see here is the gonorrhea is in purple, and gonorrhea relatively stable over time prior to the implementation of the policy, and then the purple dotted line decreasing after people switched to doxypep. So this, with individual level data, we were seeing a decrease. So some important other abstracts, Dr. Janelle Stewart from the DPEP study in Kenya, which was examining doxypep in women. This was the adherence data that Dr. Gandhi's lab did, showing that doxy only was detected in 29% of hair samples, suggesting that adherence was the determinant of low efficacy, with less use among those who were less than age 24. Consistent with what we've seen with oral PrEP, with that group having the greatest oral PrEP adherence challenges. Oliver Bacon presented the doxypep data at City Clinic, and their decreased chlamydia and syphilis were seen similarly dramatically, with a trend towards decreased gonorrhea decrease, although that was a smaller study, so maybe not powered to see the gonorrhea change. And then Dr. Stewart had another abstract looking at trichomonas, some in vitro data, doxy impacting trichomonas. Unfortunately, no effect, probably due to low adherence. Okay, so some takeaways. Doxypep is leading to population level impacts that are incredibly exciting on chlamydia and syphilis at the city level in an ecological analysis, but not gonorrhea. In the largest SF clinical cohort, there does appear to be an impact on gonorrhea. So I think we have to wait and see and generate more ecological data, but greater data over time. We'll need to monitor gonorrhea rates and resistance. And I'll just highlight here, there was an excellent syphilis session. Dr. Ghanem had a really great clinical management of syphilis. And the one point that I really took away from that session was need to remember now that changed my practice, that doxypep is in the milieu. And if my patient is on doxypep and has a decline in titers, I should not interpret that as successful treatment of syphilis, particularly if they present with syphilis symptoms. And so we need to continue to do the standard of care treatment for syphilis, not interpret a decline in titers with 200 milligrams of doxycycline as an effective treatment. So keep doxypep in mind and keep doing the standard of care treatment for syphilis for now. Okay. So see how we're on time, good. Okay, so these are some selected early phase studies for ART and PrEP. I couldn't cover everything, but I wanted to, good slip. I couldn't cover everything, so these were the ones that felt more clinically relevant to us. So really exciting study. Once weekly islatravir and lenacapavir maintained virologic suppression at high rates, 94%, what we've seen from many of the other registrational trials. No significant toxicities, including in the lymphocytes. So this could be our first once weekly regimen, and it's going to move forward to phase 3. I think, a certain population this could be really attractive to, and the challenge with once weekly is DOT would be really difficult to implement in, let's say, a pop-up population with that frequency of dosing. But I can see a lot of my patients who are a little bit more stable really liking a once weekly regimen. Okay, so this was another really exciting study. This was presented by Dr. Han. An ultra long acting cabotegravir formulation could allow Q4 month IM dosing. Originally got a little confused by this, but what I can say is that CAB 200 is referring to the concentration of our current approved cabotegravir, 200 milligrams per milliliter. And the CAB ultra long acting is delivering a 1600 milligram dose at essentially the same concentration as our regular CAB. And that dose maintains high levels with concentrations. So this graph here, the orange line is our current CAB, and the blue line is our is the new CAB. So you can see higher levels, the half-life is twofold higher, and the interpretation was that efficacy could be maintained for 4 months. So that's very exciting. Injection site reactions were experienced by most people in that group, but they were mostly mild. So, really exciting option. I think I would tolerate a slightly higher rate of mild injection reactions for a decreased frequency of dosing. I think my patients would as well. Okay, some honorable mentions. Unfortunately, poor tolerability of the TAF implant with a lot of scarring, et cetera. So that's not going to move forward. And then data presented by Dr. Gillespie about a novel NRTTI, so not islatravir, a novel one that will hopefully support Q-week or longer dosing, which had no impact on the CBC. So hoping this could be the first NRTTI tested for PrEP with Q-month dosing. Okay, some acknowledgements. Thanks so much to the organizers of HIV Grand Rounds and folks who donated their slides and their interpretations of their studies, and as well as the individuals who generously participated in the studies presented. That's the end.
Great. Thank you so much, Dr. Spinelli, Dr. Koss. So we can open it up for questions. Is anybody who has questions here in the audience?
This is just more kind of first of all, thank you so much. That's a huge amount of work. It was a spectacular summary. In terms of with our injectables, getting them, the potential, the feasibility, the data, so people don't have to do them in the clinic, like out of clinic. What are your thoughts, Matt? I know you can maybe comment, like, where are we at with that, and what do you see that as part of the future landscape?
Yeah, I think incredibly important. The pop-up team and Dr. Matani have done some really great work of delivering both injectable PrEP and injectable treatment in the field. Also, Natalie Wilson doing some really interesting work with Oakland with a mobile van administered treatment in PrEP. I see that as the future for the hard to reach populations. Challenges right now are all of this logistical stuff, but I do think it can be solved eventually with policy change and with our advocacy. So I'm hopeful for the future.
Yeah, I agree. I also would highlight Rupa Patel's work before she went to the CDC at Whitman Walker with, it was still in clinic, but sort of trained community health workers providing cabotegravir injections for PrEP, and thinking about expanding sort of the individuals who can, I think, both provide injections and also provide kind of great care in that context.
Maybe one thing I can just add from our pop-up experiences, we are working with a number of community-based providers to deliver injections out of clinic. A big challenge is labs. And one thing I wonder about the CARES trial and seeing that, cabotegravir or rilpivirine can be delivered with less frequent viral load monitoring for people that are doing well and are suppressed. It's a bit reassuring that maybe for people that can't come in as often, that may be okay. Although, of course, we still want to be trying to get people in for labs.
I had a related question, 2 points with PrEP rollout. I guess the first, just as a comment that, great presentation. Thank you so much. It was wonderful grand rounds. But in terms of out of clinic PrEP, there was a presentation by Ingrid Bassett in South Africa of using hair salons with a nurse located there. So kind of a proxy of clinic, but an out of clinic location that helped with PrEP retention and persistence for women attending hair salons in South Africa. That was interesting. Just to point you to outside of the US.
Sorry for missing that.
No, didn't bring up for that reason, just to add to the observations about out of clinic PrEP. The other was just those data were presented from CDC. I noticed that the cutoff date was 2022. And it looked, PrEP being approved in December 2021 is not even a year. So I was just curious if there was any updated data presented there. And just thoughts on that. I mean, obviously there's a lot of room to go. But
people asked a lot of those questions, and he was true to a CDC scientist, not willing to discuss any additional data that was not in the presentation. I do think the oral PrEP data is really clear that our local guidelines, which are now a bit outdated, and I'm working on updating them, do suggest doing an HIV viral load at oral PrEP initiation, and I still agree with that if it's available, but I do not believe for oral PrEP follow-ups require HIV viral load testing. I think the data is very clear from a variety of settings. Cabotegravir, we need more data.
I just wanted to clarify the cabotegravir Q4-month dosing. Was that for Cabril or for Cab on its own?
Cab on its own, yeah. Okay. Where rilpivirine has a more challenging PK that I don't think would be able to do that. Challenging is not the right word, but you know what I mean.
Can I just add one question? So is that 2 injections of the cabotegravir then? You mentioned it's the same concentration, but I assume higher volume.
It was done the same way as far as I understand, the same way you do it. So yeah. Currently right? Yes.
Hi, thank you for a great summary. In regards to the increase in the number of sexual partners in one of the studies and the apprehension about that.
Yeah,
if you,
study.
I assume you've all been at a party where that was discussed. If you give them condoms, they're going to have sex, etc. And so
I was for PrEP as well.
Party recently where that happened, and I was trying to come up with an answer. And then one of my friends, who's an AIDS activist from the early days, said, "Yeah, increase in sexual partners. I would certainly hope so."
Yeah. People are less afraid because we have really good biomedical tools, and I think that's a good thing. That's a evidence of our success.
Well, I think
Yeah,
that's go ahead.
I was just gonna say, I think I was just a little bit surprised with all of the comment. It felt very like 10 years ago with our like oral PrEP and how many, what changes the sexual behavior. And I sort of thought we were past that. And so I was just a little bit dismayed, but
Yeah, there was one comment that really did feel like 2010, 2013 to me. Yeah, unfortunately.
Thank you so much for that point. And I think that's a great place for us to end. So thank you so much, Dr. Koss, Dr. Spinelli, for a really great CROI report back.